My name is Dr. Paul Richardson from the Dana-Farber Cancer Institute, and it's my pleasure to be here at EBMT and to discuss with you some of the exciting new advances in the treatment of non-transplant eligible, newly diagnosed patients with myeloma. And I think what we've been seeing over certainly the last 6 to 12 months is an emerging amount of information on some of the really exciting new combination approaches available to our older patients who aren't eligible for transplant. And these of course include the introduction of daratumumab into the upfront setting. That was first of course established when there was a comparative trial of VMP plus daratumumab compared to VMP alone, led by Dr. Mari V. Mateus, and that clearly showed benefit to the addition of DARA. But I think what's been even more exciting has been the arrival of the MAIA study, led by Dr. Thierry Facon, which has shown the benefit of daratumumab when added to lenalidomide and dexamethasone, which is obviously a very well accepted and well-established regimen for newly diagnosed patients who are not eligible for transplant. I think on top of that, we've seen that the 3-drug platforms incorporating proteasome inhibition for older patients really also make sense. And these range from the use of ixazomib in combination with lenalidomide to some of the more recent data also on the adjustment of RVD to make it more tolerable to older patients. And we call that RVD light for short. And we just published that actually in the British Journal of Haematology, led by my colleague Betsy O'Donnell, in which she showed with my partner Dr. Jacob Laubach that this combination of lenalidomide and bortezomib, but given on a weekly schedule with about 3 weeks of lenalidomide and then either a 1 or 2 in the study, a 2-week break. But of course in practice we can sometimes make that a bit shorter. But this so-called RVD light approach it really does well for patients who are older and frailer. The lenalidomide is dosed at 15 milligrams, the bortezomib once a week, and lower doses of steroid are used. And what Betsy showed really nicely was a very high overall response rate, which approached 90%, excellent tolerance, and at the same time really good progression-free survival with disease control on average for about 3 years, which is quite remarkable in that setting. So I think on the one hand, the excitement with the triplets using proteasome inhibition and IMiDs, and on the other, the real breakthrough and the impact of monoclonal antibody therapy, showing that for newly diagnosed patients who are not eligible for transplant, there's some great options.